Welcome everyone to this week's MWAETC Echo. Let's go ahead and get started. We have a lot of cases to talk about today. I'm going to try to keep us moving, and I'll try to be a little quicker with the didactic today. This is part 2 in our last part of the review of the International AIDS Conference. Remember, in part 1, we talked about the Partner 2 study, which showed, again, 0 HIV transmissions with undetectable viral load and more support for U equals U, or undetectable equals untransmittable. And we talked about a study out of France supporting intermittent or pericoital PrEP use. So stay tuned for more discussions about that on ECHO. But with this, I'm going to turn to some abstracts about ART strategies and ART in the modern integrase inhibitor era. Here is my outline. So really going to focus on this study that looked at dolutegravir plus lamivudine as initial ART as 2-drug therapy for treatment-naive individuals. This made some headlines. And then I'm just going to briefly mention a few abstracts that relate to integrase inhibitor use and modern ART use to sort of stimulate thought and discussion. But first, let's talk about the Gemini studies. We kind of knew these were coming and they were anticipated. So this is looking at 2-drug dolutegravir 3TC or dolutegravir lamivudine compared to more standard 3-drug dolutegravir with TDF FTC as initial ART, so for treatment-naive individuals. So these are 2 identical double-blind, multinational, industry-sponsored, non-inferiority randomized controlled trials. Again, looking at 2-drug versus 3-drug therapy, you can see the 2 arms here and the number that were randomized 1-to-1 to each arm, just over 700 in each group. This randomized control trial was motivated by these 2 single-arm pilot studies, which we've talked about before. Remember, PADL was only about 20 individuals, but showed that this 2-drug initial ART strategy was promising. ACTG 5353 was 120 people, again showed promising results. About 90% suppression, if I remember right, but there was 1 individual in that 5353 study who failed and did develop NNRTI and integrase inhibitor resistance, which sort of raised eyebrows, and we didn't know what to make of that. So now we have a more fully powered randomized trial that enrolled treatment-naive individuals with viral loads between 1,000 and 500,000. So individuals could not have baseline screening viral loads above 500,000. They had no evidence of resistance, no chronic Hep B. Importantly, this 2-drug regimen would not be complete therapy for Hep B. And what was noted in the inclusion criteria was no need for Hep C therapy, though I couldn't quite sort out how they defined that. But the endpoint was the percent with an HIV RNA or viral load below 50 copies at 48 weeks by intention to treat, meaning that both virologic failures or missing data were counted as failures. Here are the baseline characteristics. So again, just over 700 in both the 2-drug arm and the 3-drug arm. You can see here the median age. As in many ART trials, a relatively low percentage of female participants. You can see the median CD4, the percent with a CD4 below 200, the median HIV RNA log, and about 20% in either arm with a viral load above 100,000, though remember they could not have a viral load above 500,000. And here is the key result. So overall, 90% compared to 93% had an HIV RNA below 50 copies at 48 weeks. This was a non-inferior result. So 2-drug dolutegravir lamivudine demonstrated non-inferiority to 3-drug dolutegravir and TDF FTC as initial therapy at 48 weeks. One of the reasons this is notable is dolutegravir 3TC is likely going to be combined into a single pill relatively soon. A couple of other notes I'm not going to show you in detail, but just going to highlight. There were similar results regardless of the baseline viral load. So regardless of whether viral load was below 100,000 or whether it was 100,000 to 500,000, this 2-drug regimen did demonstrate non-inferiority. There was a slight difference, a slight lower response rate in the 2-drug arm with those who had CD4 count below 200, but it wasn't due to virologic failures. It was more due to other miscellaneous reasons. So I don't really know what to make of that, if anything. There was no treatment-emergent resistance to any study drug in either arm here. And I think that's important, again, following up on ACTG 5353, which had that 1 individual with NNRTI and integrase resistance, and really raised the question of, is 2-drug therapy more risky in terms of resistance development? And this much more fully powered study would argue that it is not. Not surprisingly, the changes in renal and bone biomarkers favored the 2-drug arm in which TDF was avoided. Lipids were a tiny bit better in the TDF arm, but I don't think in a clinically significant way. So The investigator conclusion is that these results support dolutegravir 3TC as two-drug initial ART, and it was non-inferior to the standard triple ART arm. So here's my question to you, to all of those of you in the community and on the panel here. When would you reach for this? Is this going to change your practice? Do we need two-drug initial ART? Who might you offer two-drug therapy as their first ever regimen? So I'll just let you think about that. I would not say this is changing my practice in any immediate way, but I do think it adds support if, say, somebody has very severe renal impairment or other reasons they cannot get standard 2-NRTI, including regimens, that we could at least consider this dual therapy. So I'll let you ponder that. I'd be curious to hear everybody's opinion of when you might reach for this and whether it will change your practice. Before I turn to some other abstracts, let me just kind of give a summary. I've shown this before, and I'm just trying to keep track of sort of two-drug regimens and where we're at in terms of what's been published and what's been presented. And I just posed this question as well. Yeah, there's a lot of studies going on. Is two-drug ART the future, either for initial ART, now that we have published randomized controlled trials like Gemini and Andes, and then we also have some pilot studies that have been presented, like for darunavir plus rilpivirine. So, is this the future, and when might you reach for these? And then for maintenance ART, as we've talked about, two-drug dolutegravir rilpivirine is approved as a two-drug combo tablet for very select individuals, and then we have a kind of a growing body of data for these other regimens. So, food for thought. But with that, a few abstracts related to modern ART that I just want to present to stimulate thought and discussion. So these are some things that caught my eye. So one, an update on the risks of dolutegravir during conception. So we've reviewed the recent FDA warning and the New England Journal paper suggesting that dolutegravir may raise risk of neural tube defects if taken by a woman at the time of conception. So we got an update from the investigators who initially presented this. So there were no additional neural tube defects through July 15th, 2018. So the estimated incidence of neural tube defects in women conceiving on dolutegravir in this trial in Botswana is now 0.67%. Remember, in the New England Journal study, what led to the warning was 0.9%. So a slightly lower estimate now that we have higher numbers. But again, this is different than the 0.12% with non-dolutegravir ART, which is primarily efavirenz. So hopefully we'll have more data and more guidance on this in the future. Just a reminder, for right now, there are recommendations in the DHHS guidelines for both screening for pregnancy prior to starting dolutegravir and for options if a woman is trying to conceive or conceives on dolutegravir, and we've reviewed that here. This Dolphin 1 study also looked at dolutegravir during pregnancy, but not at time of conception, started later in pregnancy after 28 weeks. And although numbers were small, this and several other publications really do support that dolutegravir started later in pregnancy is safe. And in this trial, it actually started after 28 weeks, led to higher rates and faster viral suppression than efavirenz, not surprisingly. So again, there's concern right now about dolutegravir taken at the time of conception, but a fair amount of data suggesting that it is safe when started later in pregnancy. We also got an update at the IAS conference about the SWORD trials, this maintenance study looking at a switch to dolutegravir rilpivirine two-drug therapy. We now have data all the way out to 100 weeks. Again, individuals are selected very carefully for switching to this regimen. They must be suppressed for a number of months. They cannot have prior virologic failure or prior resistance, but if selected carefully like that, it does appear to be an effective maintenance strategy. Interestingly, 3 participants developed virologic failure with rilpivirine or NNRTI resistance, but there was no integrase resistance. So it appears that if people fail this two-drug maintenance strategy, they are at risk of NNRTI mutations. Probably could still be salvaged with other classes, but it does not seem like integrase inhibitor resistance happens, which is reassuring. There was another trial, I'll just mention briefly, confirming that we should not be doing dolutegravir monotherapy. We've talked about that before. Dolutegravir monotherapy, just don't do it. And then there was a case report of dolutegravir resistance developing in someone who started a 3-drug dolutegravir regimen as their first regimen ever. This is so notable because this is only the second case report ever of somebody starting dolutegravir as part of their first regimen and then developing dolutegravir resistance. The mutation that happened was pretty minor. Dolutegravir was still pretty active, but I highlight this because it is so rare that somebody develops dolutegravir resistance after starting it as their first ever regimen. Like the other case report, this person had very advanced HIV with a very low CD4 count, a high viral load, and an active infection. And this person was actually receiving rifampin as part of treatment for an invasive Staph aureus infection, so was getting BID dolutegravir dosing. So it appears that in rare circumstances with very ill individuals, maybe a person who starts dolutegravir as their first regimen could be at risk for dolutegravir resistance, but it's still so rare that if you find it, write it up as a case report because it is just that uncommon. Finally, a couple of other abstracts that are notable. So this one really caught my eye. The group out of MGH led by Emily Heil and Rochelle Walensky, who do a lot of really interesting cost-effectiveness modeling, modeled whether or not we really need to be doing genotypes at baseline at all. Now that we're starting everyone on integrase inhibitors and transmitted integrase resistance is so rare, and we're starting most people on dolutegravir or bictegravir, does it really make sense to check baseline genotypes? When we were starting everybody on ATRIPLA, it was absolutely necessary because transmitted NNRTI resistance happens frequently enough. But now that we're now in the integrase inhibitor era, does it really make sense to check genotypes at baseline? Their modeling analysis, and there certainly are limitations to mathematical modeling, suggested that it is not cost effective and perhaps not necessary. I am still going to be doing it because it's in the guidelines. And I think we need to know more, but I think it's really intriguing to think about whether it is still necessary. There was an abstract looking at integrase resistance between dolutegravir, bictegravir, the latest integrase inhibitor to be approved, and cabotegravir, the integrase inhibitor in development, and did show that the resistance patterns overlap. With all of these drugs, the worst scenario is the Q148 pathway plus secondary mutations. And so it does seem that in that pathway, none of these integrase inhibitors are an option. And then finally, I'm intentionally not reviewing this in more detail because I'm skeptical about it, but this study has raised eyebrows as well. So study 1824 is an open label switch to elvitegravir, cobicistat, FTC-TAF, which is Genvoya, in the setting of a suppressed viral load and an M184V. Again, individuals were very carefully chosen for this trial, and it was very small, which is one of the reasons I'm waiting for more data. So only 37 individuals. But for these folks who were suppressed long-term and had an M184V, switching to Genvoya did maintain viral suppression. I have concern about this because, again, I think in these switch trials, people are very carefully chosen. I think there is selection bias. All of these individuals basically had a suppressed viral load on only 3 ARVs at baseline. So I think they are selecting for individuals who've proven they can suppress on only 3 drugs with a 184V, and it's only 37 patients. But bigger studies are planned, and there are studies even looking at switching to Genvoya with a 184V and up to 2 TAMs. So I personally do not recommend this strategy. I'm interested to see what else comes of this. But I throw this out there because it has led to a lot of discussion. Last interesting note from this, all of these individuals, 37, were known to have a 184V or 184I on a past traditional standard RNA genotype. A DNA genotype only picked that 184V up in about half or under half. So again, they also highlighted the limitations of using DNA or archived genotypes. So that's a quick run through of the Gemini study and some abstracts that caught my eye about modern ART use. We do have a lot of cases to discuss today, but I will pause there, take a couple minutes for questions or comments from the community or from the panel here.